Our final chapter that we will discuss today is Chapter 51, Care of Patients with Ear and Hearing Problems. The ears are important for the sense of hearing and for balance. Ear disorders can cause many problems ranging from hearing difficulty to problems of balance and functional ability leading to confusion, mistrust, social isolation, and the inability to give and receive accurate information. Disorders of the external ear include congenital malformations, trauma, and infections or non-infectious lesions of the pinna, auricle, or auditory canal. Next, we're going to look at conditions affecting the external and middle ear. External otitis is a painful condition caused when irritating or ineffective agents come into contact with the skin of the external ear. Treatment focuses on reducing inflammation, edema, and pain through topical antibiotics, steroids, and comfort measures. Teach patients the proper way to clean the pinna and external ear canal. Furuncle is a localized external otitis caused by bacterial infection, usually Staphylococcus, of a hair follicle or by inserting inappropriate objects into the canal. Treatment consists of local and systemic antibiotics and local heat application. Perichondritis, caused by ear piercings or contact sports, is an infection of the perichondrium, a tough fibrous layer that surrounds the cartilage and gives shapes to the pinna. Treatment consists of systemic antibiotic therapy, and often a wide incision is made and suction drainage is used. Cerumen, or foreign bodies, are the most common cause of an impacted canal, although earwax can also earwax is the most common. However, objects can also be placed in the external ear canal, such as vegetables, beads, pencil erasers, and insects. Removal of cerumen obstruction by irrigation is slow but may improve hearing. Do not irrigate an ear with an eardrum perforation or otitis media or when the foreign object is vegetable matter, because this matter expands when wet. Conditions affecting the middle ear include otitis media. The three most common forms of otitis media are acute otitis media, chronic otitis media, and serous otitis media. Each type affects the middle ear but has slightly different causes, incidences, and pathologic changes, and if untreated may result in permanent conductive hearing loss. Mastoiditis is an infection of the mastoid ear cells caused by untreated or inadequately treated otitis media. Trauma and damage may occur to the eardrum and ossicles by infection, by direct damage, or through rapid changes in the middle ear cavity pressure. Neoplasms. Although tumors of the middle ear are rare, the most common is a glomus jugular, a highly vascular benign lesion arising from the jugular vein. Cancerous ear tumors include adenocarcinoma, adenoid cystic carcinoma, and mucoepidermoid carcinoma, which disrupt conductive hearing, erode the ossicles, and may spread to the inner ear and nearby cranial nerves. So let's look at otitis media. Again, the three primary types are acute, chronic, and serous. The picture here on the left, you see an otoscopic view of otitis media. On the right, you see an otoscopic view of a perforated tympanic membrane. So let's look at acute and chronic otitis media. Acute otitis media and chronic otitis media, also known as purulent otitis media, are similar. An infecting agent in the middle ear causes inflammation of the mucosa, leading to swelling and irritation of the small bones, the ossicles within the middle ear, followed by purulent inflammatory exudate. Acute disease has a sudden onset and lasts 3 weeks or less. Chronic otitis media often follows repeated acute episodes, has a longer duration, and causes greater middle ear injury. It may be a result of the continuing presence of a biofilm in the middle ear. The patient with acute or chronic otitis media has ear pain with and without movement of the external ear. Acute otitis media causes more intense pain. As the pressure in the middle ear increases, there is a sensation of fullness in the ear. Hearing is reduced and distorted. Conductive hearing loss may occur as sound wave transmission is obstructed. Headaches and systemic symptoms such as malaise, fever, nausea, and vomiting can occur. As the pressure of the middle ear pushes against the inner ear, the patient may have dizziness or vertigo. Otoscopic examination findings vary depending on the stage of the condition. If the condition progresses, the eardrum spontaneously perforates or ruptures, and pus or blood drains from the ear. When the membrane ruptures, the patient notices a marked decrease in pain as the pressure on middle ear structures is relieved. Serous otitis media with effusion, also called serous otitis media, is simply a collection of fluid that occurs within the middle ear space due to negative pressure produced by altered eustachian tube function. This can occur purely from a viral upper respiratory infection with no pain or bacterial infection, or it can be preceded and or follow acute bacterial otitis media. So remember to use a separate speculum cover for each ear when conducting an otoscopic examination. Slowly and gently introduce the otoscopic speculum into the external ear canal during assessment. Use contact precautions with any patient who has drainage from the ear canal, and avoid performing an otoscopic examination on a confused or uncooperative patient. So let's look at some types of interventions. Infection control. Always clean all equipment and do not reuse otoscope covers on different patients. Topical antibiotics are not used to treat otitis media. Systemic antibiotic therapy decreases pain by reducing inflammation. Teach the patient to complete antibiotic therapy as prescribed and to not stop taking the drug when manifestations are no longer present. Stopping the drug early may cause a reinfection. Antihistamines and decongestants decrease mucus production and fluid in the middle ear. An operative procedure called a myringotomy may be used to remove fluid and is usually done without anesthesia. This procedure drains middle ear fluid and relieves pain. Many people are concerned about a perforation and its effect on healing. To relieve some of this anxiety, discuss the reasons for the procedure and encourage the patient to use techniques such as deep breathing before and during the procedure. Systemic antibiotic therapy continues before and after the myringotomy. The operative procedure is a small surgical incision often performed in an office or clinic setting and heals rapidly. Another approach is the removal of fluid from the middle ear with a needle, for relief of pressure caused by serious otitis media and for those patients who have repeated episodes of otitis media. Another option would be a polyurethane tube that is surgically placed through the eardrum to allow continuous drainage of middle ear fluids. Postoperative care includes teaching the patient to keep the external ear and canal free of other substances while the incision is healing. Instruct the patient to keep the head dry by not washing the hair or showering for several days. Now we're going to look at irrigation of the external ear. Cerumen and debris can be removed from the ear by irrigation with warm water. The stream of water is aimed above or below the impaction to allow back pressure to push it out rather than push it further down the canal, as you can see in this illustration. Assist the patient to a sitting or lying position with the head tilted toward the affected ear. Place a waterproof pad and drainage receptacle under the affected ear. Check the temperature of the irrigation. It should be 37 degrees Celsius or 98 degrees Fahrenheit. Ensure the tympanic membrane is intact before beginning an irrigation and that the patient does not have otitis media. Straighten the ear canal and gently insert the syringe tip. Do not use blasts of pressure and do not direct the water stream toward the tympanic membrane. Follow instructions on page 1091 of your textbooks for further information. Let's look at some conditions affecting the inner ear. First one is tinnitus. Continuous ringing or noise perception in the ear is very common. Diagnostic testing cannot confirm tinnitus, but it is used to assess hearing and rule out other ear and hearing disorders. When no cause can be found or the disorder is untreatable, therapy focuses on ways to mask tinnitus with background sound, noisemakers, and music during sleep. Vertigo and dizziness are common manifestations of many ear disorders. Dizziness is a disturbed sense of a person's relationship to space, and true vertigo is a real sense of whirling or turning in space. Many patients are dissatisfied with treatments because side effects of the drugs typically cause drowsiness and can be worse than the vertigo itself. Use fall precautions with patients with vertigo or dizziness and assist with ambulation. Teach patients to maintain a safe, uncluttered environment to prevent accidents during periods of vertigo, to use a cane or walker to maintain balance, and not to drive or operate machinery when taking medications. Labyrinthitis is an infection of the labyrinth which may occur as a complication of acute or chronic otitis media. It often results from the growth of cholesteatoma, a benign overgrowth of squamous cell epithelium from the middle ear in the semicircular canal. Treatment of the disease includes the use of systemic antibiotics. Meniere's disease has three features: tinnitus, one-sided sensorineural hearing loss, and vertigo occurring in attacks that can last for several days. The exact cause of Meniere's disease is unknown, but it often occurs with infections, allergic reactions, and fluid imbalances or long-term stress. Treatments may include dietary and lifestyle changes, avoid smoking, and drug therapy. Another non-surgical treatment is the Menyet device, believed to displace fluid from the inner ear, thus relieving symptoms. Radical therapy involves resection of the vestibular nerve or total removal of the labyrinth performed through the ear canal. Acoustic neuroma is a benign tumor of cranial nerve 8 which may impact hearing, facial movements, and sensation as it grows. Acoustic neuromas are diagnosed with the computer tomography scanning and MRI imaging. Surgical removal via craniotomy is performed. Hearing loss is one of the most common handicaps in North America and can be conductive, sensory neural, or a combination of the two. Conductive hearing loss can be caused by an inflammation or obstruction of the external or middle ear by cerumen, foreign objects that lead to conductive hearing loss. Sensory neural hearing loss occurs when the inner ear auditory nerve is damaged. And presbycusis is a sensory neural hearing loss that occurs as a result of aging. Interventions include early detection of hearing impairment, drug therapy, and comfort measures, and assistive devices to amplify or augment auditory perception. Cochlear implantation may help patients with sensorineural hearing loss. Tympanoplasty reconstructs the middle ear to improve conductive hearing loss. The procedures vary from simple reconstruction of the eardrum, myringoplasty, to replacement of the ossicles within the middle ear. A partial or complete stapendectomy with a prosthesis corrects hearing loss, especially in patients with hearing loss related to osteosclerosis. A newly approved device to treat bilateral, moderate to severe sensorineural hearing loss is the Esteem system. It is designed to improve hearing to the same or better level as a high-quality hearing aid, but without any visible part. The device has 3 components that are totally implanted: a sound processor, a sensor, and a computer driver. So now we're going to look at anatomy of hearing loss. Again, as we've stated earlier, hearing loss can be divided into 3 types: conductive, sensorineural, and mixed conductive sensorineural. So conductive hearing loss can be caused by inflammation, obstruction of the external or middle ear by cerumen, foreign bodies, tumor, scar tissue, and an overgrowth of soft bony tissue on the ossicles from previous middle ear surgery also leads to conductive hearing loss. Sensorineural hearing loss occurs when the inner ear or auditory nerve, cranial nerve 8, is damaged. Prolonged exposure to loud noises can damage the hair cells on the cochlea. Many drugs are ototoxic to the inner ear structures, and their effects on hearing can be transient or permanent, dose-related or non-dose related, and affect one or both ears. When ototoxic drugs such as antibiotics and often gentamicin specifically are given to patients with reduced kidney function, increased ototoxicity can result because drug elimination is slower. Older patients are especially at risk for ototoxicity because of reduced kidney function. Because hearing loss may be gradual and affect only some aspects of hearing, many adults are unaware their hearing is impaired. The actual incidence of hearing loss is not known, but hearing loss dramatically increases among people in their 70s and 80s. Although nurses should not assume that all older adults have a hearing loss, it is important to use communication techniques that improve information transfer in all situations. These include facing the patient during any communication, ensuring your mouth is visible when you speak to the patient. Make the environment as quiet as possible by turning off radios and televisions, closing the doors, speaking clearly and at a pace that is slightly slower. Ask the patient to repeat the main points of what has been said in his or her own words, and observe the patient's face and body language for cues that communication was indeed effective. There are many different types of interventions for patients. Remember to encourage everyone to have simple hearing testing performed as part of their annual health assessment. Teach everyone the danger of using foreign objects such as bobby pins, Q-tips, toothpicks, keys to clear their ear canal. These objects can scrape the skin of the canal, push cerumen up against the eardrum, and even puncture the eardrum. Explain that nothing smaller than a person's own fingertip should be inserted into the canal. If cerumen buildup is a problem, teach the person to use ear irrigation syringe and proper solutions to remove it. The final part of this PowerPoint will be delivered in the next segment.